why are there differences in ACL injury rates between male and female athletes? Okay, so to answer a question brings us to our learning objectives. So for number one, how do injury rates differ when comparing male and female athletes? Number two, we want to explain the anatomical differences between male and female athletes that lead to higher injury rate of ACL in females. And for number three, same thing, but we're just trying to explain the molecular and hormonal differences between male and female athletes that lead to a higher rate of ACL injury in females.
Alright, it's time for a pre-quiz. Take a moment to think of some of the anatomical structures that contribute to the differences. As a hint, bony landmarks. And then take another moment to think of some of the possible hormonal differences.
So I'm just going to quickly talk about the mechanism of ACL injuries. So ACL injuries usually occur in sports that involve a lot of pivoting and sudden deceleration, like you've seen earlier. I just want to briefly mention the point of no return. So first, we have tibia, internal or external rotation. So this is a tibia. When the tibia internal rotates or external rotates, like that. And then second, we have the femur, internal rotation. So this is the femur. We're going to internal rotate like that. And thirdly, we have the knee when it's in valgus, and then when it's less flexed, so it's kind of extended like that. And then lastly, we have the foot when it's out of balance or out of control and unbalanced.
Okay, so what about the epidemiology of ACL injuries? Many studies have reported average incidence being around 30 or 45 per 100 person years in US, and more than 120,000 ACL reconstructions are performed annually in USA. Studies have reported a 2 to 9-fold increase in the relative risk of ACL rupture in female athletes compared to male athletes. Let's talk about why these differences happen. We're going to start talking about the hormonal differences. The first example, and maybe the most obvious one, is the differences in estrogen levels between male and female athletes. Many studies have reported an increased knee laxity when estrogen levels are higher during the menstrual cycle. And as a result, there is a concomitant increase in the number of ACL injuries in athletic women during the menstrual cycle when the estrogen levels are higher, as we can see from this graph. And high estrogen levels were shown to reduce the activity of an enzyme called lysyl oxidase, which is responsible for creating the cross-linkings in the collagen structure, which results in decreased ligament stiffness during high estrogen level periods.
Another hormone involved in the differences that might not be so obvious is relaxin. Relaxin is a hormone that's actually involved in ligament catabolism. It was found that females with ACL tears actually had a higher concentration of relaxin compared to males, and relaxin-treated animals also had significantly weaker ACLs as well. In vitro, ACLs exposed to relaxin actually had lower enzymes involved with collagen expression and higher enzymes involved with collagen degradation. There was also a decrease in smooth muscle actin and collagen synthesis. Female ACLs in vitro primed with estrogen also had lower collagen expression compared to non-primed ACLs, and in males there was no significant differences. Another important difference between the male and female ACL is the makeup of the collagen itself. As we all know, ACL is made up of collagen types 1 through 3, but there was an inherent difference found between the collagen expression in males and females. Male ACLs were found to have a much higher collagen 1 expression, but the collagen 3 expression was relatively the same. The reason why this is significant is because collagen 1 has an enormous tensile strength compared to collagen type 3, and it was found to be more stronger gram for gram when compared to steel.
Okay, so next we're going to talk about the anatomical differences. We have the mechanical property of ACL. We also have the size of ACL within the intercondylar notch. We have the quadricep angle, which is also called a Q angle, and we have the hamstring flexibility.
First, I'm going to talk about the mechanical property of ACL and a cadaveric study by Chandrasekhar and colleagues, which measured mechanical property by strain at failure, stress at failure, and modulus of elasticity, show that female ACLs have a lower mechanical quality than male ACLs. And why is this important? Because mechanical property of the ACL may influence its ability to sustain increased loads. And this might play a major role in the high incidence of ACL injury in female athletes. Second thing I'm going to be talking about is the size of the ACL within the intercondylar notch. So first thing is female ACLs are smaller than male ACLs when normalized for body weight. And second, a smaller ACL encounters a greater amount of stress when force is applied to the knee joint. And also, several studies have shown a positive correlation between small ACLs and injury risk.
Okay, so the third point we want to talk about is the Q angle. And how do we find the Q angle? So we find the midpoint of the patella, and then you find the tibial tubercle. So you draw a line there. And second, you find the midpoint of your patella again, and then your ASIS, and you draw a line there. So the angle between those lines is the Q angle. The measurement of Q angle is a little tricky because the variability in the measurement procedure will alter the outcome. Typically, the Q angle is less than 15 degrees in men and then less than 20 degrees in women. The key point here is it's usually shown to be way higher in women. So when your Q angle is greater than 20 degrees, that's going to increase the risk of pulling of your kneecap laterally, which increase the risk of knee disorders.
That's going to be our activity for today. So just form groups of 4 and we'll be showing you how to measure the Q angle. Okay, so first we start from the midpoint of the patella and draw a line to the ASIS, the anterior superior iliac spine. And then we have another line drawn from the midpoint of the patella through the tibial tubercle. And this angle here is known as the Q angle. So the last anatomical difference we're going to be talking about is hamstring flexibility. So Hewitt et al. Showed that after puberty, boys show a significant decrease in flexibility compared to girls, and they use a sit and reach test that we all did in grade 8. Increased hamstring flexibility, they hypothesize, may be responsible for this decreased dynamic control of the knee in females. And they said that lax hamstrings may delay hamstring muscle activation, and so in doing that, it'll delay the co-activation of the quadriceps. And this is all shown to stabilize the knee. As I said, so co-activation of these muscles is necessary to protect the knee joint against excessive anterior drops, so pulling the kneecap laterally, and essentially stabilize the surrounding ligaments. So it's time for the post-quiz now. First question, what degree of Q angle would give you the most issues with the knee? So if you answered greater than 20 degrees, you are correct. Give yourself a pat on the back. Second question, list some of the hormones or molecular differences that are related to the greater risk in female athletes. So answers can include estrogen, relaxin, and the differences in collagen makeup.
Okay, so now as a summary, let's come back to our learning objectives. We now know that ACL injury rates are 2 to 9 times higher in female than male athletes. And the reasons for these differences include the anatomical differences, such as the mechanical property of the ACL, the size of the ACL within the intercondylar notch, the Q angle, and the hamstring flexibility. We have also the molecular or hormonal differences, which include the estrogen levels, the relaxin, and the differences in the collagen makeup.
Oh, now that makes sense.